Good evening, friends. On behalf of the Shankar Netrala Alumni Association, I have the greatest pleasure of welcoming you all for this SN Alumni Connect Series webinar. We had about 2 weeks back a webinar on retinal potpourri, which was actually an amazing success and it was very well discussed. All the topics are very nice. We had also Rajiv Raman on the panel as well, and Dr. Natajan, Chetan Rao, and many other people as well. Today, because on the eve of the World Diabetic Day tomorrow, we are focusing on diabetic retinopathy, and we got an interesting line of speakers. We have the gold standard of diabetic retinopathy, Dr. Rajiv Raman here, who's going to talk about artificial intelligence in diabetic retinopathy diagnosis. And of course, the whole session will be moderated by Dr. Manoj Khatri. And we have got a fantastic lineup of speakers as well. Dr. Padmaja, Dr. Sapnesh, Dr. Manish, Dr. Rupak, and they'll be also talking on diabetic retinopathy. Let's have a good discussion also at the end of it, because the current problem, I would say the epidemic in our country is the diabetic retinopathy. And just like myopia, the diabetic retinopathy also, as you all know, is on the increasing trend. These few words, as the president of the alumni, I also appeal to you, all of you, to stand, show the solidarity in the days to come for our AOS elections. You know that I'm also contesting for the AOS elections, and SN Alumni, as you all know, is one of the strongest alumni association in the entire country. And we got a huge number of people, more than 1,500, 2,000 alumni are there, including the Ratan Tata Fellowship people as well. And wherever I go, every nook and corner, every part of India, every part of the world, I see SN alumni doing so very well and practicing very ethically as well. And we are all very proud to be alma maters of this great institution, the Temple of the Eye. And next week, don't forget the date, November, I think 21st is the memorial death anniversary of our chief guru, Dr. SSB. And we are also having a function on 23rd. Dr. TSS sent an invitation yesterday, wherein Dr. Nam Parmal Swami is giving the lecture for the Dr. Badrinath Memorial Lecture. So, Dr. Manoj, you take over the entire proceedings, and we'll have some fruitful discussion also at the end of it.
Thank you so very much, sir, and good evening, one and all. This focused webinar today by SN Alumni Association on the eve of World Diabetes Day is focused mainly on diabetic retinopathy. As we all know, Shankar Netralaya has done some landmark research work as well as clinical work for the treatment of diabetic retinopathy in this part of the world. We were very fortunate to be associated and part of this mega project. Also, we'd like to appeal to all of you that don't ever forget that All India Ophthalmic Society 2025 elections are on the cards, and our own SN Alumni Association President, Dr. Mohan Rajan sir, is contesting for the post of Vice President, and we need to wholeheartedly support him and get all our SN alumni as well as other friends together to work towards his candidature and support him wholeheartedly and make him win the elections by a huge margin. So with these few words, let's move on to the first talk of the evening. Will be none other than Dr. Rajiv Raman. He needs no introduction, a guru, teacher, mentor for many, as well as a name synonymous with diabetic retinopathy in this part of the world, I will say. So we are very fortunate to have him here. He will be talking to us what future lies for diabetic retinopathy, especially on the artificial intelligence platform. Over to you, RRN sir, and we look forward for your talk.
Thank you. I'll just share my slides. Let me. My slides are visible?
Yes, sir, visible and you're audible. Just put a screenshot.
Yeah, great. I'll
Yes, sir.
just reduce this. Yeah. So thanks, Manoj, for the kind words. And I think on the World Diabetes Day, this year, the theme of World Diabetes Day is the breaking barriers and bridging gaps. And I think AI is something which can do both. It has a potential to do both. And let's see what is there in AI for diabetic retinopathy. What are the newer frontiers? What new is happening today as far as AI is concerned? So diabetic retinopathy poses some challenges which are very pertinent to this disease, both as far as screening and treatment are concerned. It's a disease of varying epidemiology. Even regional differences are there. And the paradox is that countries like India having lower prevalence than West, but the problem is the high absolute numbers. So very recently, we did this countrywide epidemiology study called a Smart India study. And we did find that we do have nearly 101 million people with diabetes, overall prevalence being about 12.5%. It's a major public health problem in our country. The second major issue is that we don't have a structured retinopathy screening program. We have a lot of screening methodologies which are very well laid down. We have AIOS guidelines. Recently, we also have the RSSDI guidelines. So there are guidelines how to screen for retinopathy. However, we don't have a very well-established public as well as private pathway of screening diabetic retinopathy. If we think that retinal photography is the best way to screen diabetic retinopathy, we have nearly, if you even look at vision-threatening retinopathy, today we have nearly 4 million people with vision-threatening retinopathy. And you think that you want to do a retinal photography for 101 million people, and that too annually, that doesn't seem to be a very feasible solution. More recently, we have many of these AI algorithms which are also able to predict the treatment response. And when these algorithms came, we were thinking that probably this will change the way we manage retinopathy, but it's not true. They don't have explainability, and many of them, the acceptability is very limited. So I will describe these new frontiers in 3 headings. What are the emerging innovations? Now, these are the ones which are currently there, which have already been made. They have been used by a few groups. You have some which are potential breakthroughs, which are something which you can see in next coming years. There are pilot projects which have been very successful, and then something on the future perspectives as far as AI is concerned. So let's look into some emerging innovations which are happening in AI for diabetic retinopathy. So we do know that there are a couple of AI-enabled non-mydriatic cameras today. So retinal cameras have integrated AI platform to detect diabetic retinopathy, even tell the stage of retinopathy. This also made the AI-driven telemedicine, because these cameras with this as well as transferring these images has made telemedicine also possible. And even now we have many of these cameras come with AI-driven detection for gradability, whether the image would be gradable or not. And if it's a non-gradable image, it can prompt the photographer to retake the image. And many of these commercial available cameras have got well proven, researched algorithms which are inbuilt, like Carl Zeiss Visual Scout is integrated with Selena, which is the AI algorithm made by Seri Singapore. Forus has their own algorithm, plus very recently they've also integrated with Google Arda, the Google AI platform, and Remedio AI has its own algorithm, which is also very well researched and published and shown to have a very high accuracy. So this is something which is already available in our country. The other concept which is coming up, especially with a country like ours, where we have a huge burden of diabetes, is the concept of pre-screening for retinopathy. That probably, if you think that we can screen 101 million, it is not possible. but we can probably do a pre-screening, a risk factor-based algorithm, or probably a blood-based marker, and reduce these numbers, and the numbers who are on the patients who have a higher score or have more risk factors, probably do a screening for them using a retinal camera based AI algorithm. This was based on all the population-based studies which are there in India. We developed who had used a retinal photograph for grading. We used all these photographs as well as the metadata associated with them and created a machine learning algorithm to rank the risk factors based on. So this means that using these algorithms, we could identify what are the important risk factors, and based on their weight, which it gives for development of diabetic retinopathy, we made a AI algorithm. The accuracy of decision tree being about 0.8, meaning reasonable good accuracy to predict the presence of DR even without a retinal photograph. So basically you need in this age, systolic diastolic blood pressure, BMI, duration of diabetes, and FBS status. And if you fill all these things, it starts giving the prediction. And like this case, the probability of having a positive diabetic retinopathy is 0.98, means again very high. And these are the patients who probably need a second level screening by a retinal camera. So these are two things. We have a lot of these cameras. We have algorithms which can pre-screen. And we also have now very accurate algorithms which can detect the progression of diabetic retinopathy. When we use these, which was published in Nature Medicine earlier this year, we used it for SN Dreams, the population-based data set from Shankar Nethralaya. We did find that the average screening interval of nearly annually could be increased to nearly 32 months. And this actually suggests that nearly 62% reduction in frequency of screening can be achieved. And the delayed detection rate was only 0.37%. Means now we have a system, you pre-screen, you screen, and then we can also predict with a high accuracy how this disease will progress over a period of 4 years. So this study was validated across 8 countries, and from India it was the SN Dreams data set. And you can see the very high AUCs, that means very high accuracies in detecting the progression, how many of mild will progress to moderate, severe, or PDR and DME. So these were some of the things which are already available. So we have these things which are there, but they are definitely innovations in their own sense. And you will soon see these coming into our clinical practice. The first one is already there. There are certain potential breakthroughs. These are the ones which have been used as pilot, but definitely they have a large scope as far as diabetic retinopathy is concerned. So one breakthrough has been that it's not only the deep learning, but even integrating large language models in diabetic retinopathy screening pathways. This was a work which was done by Professor Tin Wong, and happy that we were part of it, and we could really use this integrated platform using deep learning and large language model in a diabetes care setting and see that how we can really change. So it could actually not only give the diagnosis of diabetic retinopathy, but also give a recommendation for diabetic retinopathy and for diabetes. And it was not only, it exceeded we compared it with physicians, so it exceeded or matched these primary care physicians, even in areas of empathy, which we think that probably AI will not do. And this was again published a couple of months back in Nature Medicine. And this is something which is a new thing, and soon you'll have many of these models which are not only deep learning but combined with large language models. Another one which was very recently in April of 2024, this paper was published. It was not related to ophthalmology, but it was mainly for dermatology. But this has been now widely used in ophthalmology. So these are actually to improve the fairness of medical classifiers. So many of the diseases, we have less number of images, and traditionally we have these GANs, the generative AI which is used, or some autoencoders are used to generate images. Now, diffusion model is the one which they have described a new technique, which actually is a little higher level. You get more close to reality, these synthetic images. So basically, it's a two-step process. They add the noise and then reverse it and create an image step by step. And you can condition the diffusion model like you want specific age or disease severity that can be targeted. So it is with a very limited data set, you can actually create a large data and work. And this has been shown successfully in even histopathology, even in dermatology. And now people are trying to use these models for diabetic retinopathy. So it can create synthetic image in an unrepresented group. Like you have many times when we deal with these data, the early stage of non-proliferative retinopathy, mild NPDR numbers are less. And this is something which can create these images and make a more a model with a data which is fairly representative of all the severity. Even we know that real world setting, the images may vary due to the different camera types and lighting. And these synthetic images can be created, which can make the AI model more robust. Again, as I said, that usually for making these algorithms, you need a large number of labeled data. It's often very time consuming. And these diffusion models can fill the gap by creating a realistic synthetic image, which can be used for retinopathy, any AI project related to diabetic retinopathy. Another potential breakthrough which has happened are these foundation models. These are like your chat GPTs, but models which have been generated only for using retinal image. Millions of images have been utilized to create these models. The first one was by Dr. Pierce Keen from Moorfields, and the second comes from China. And these are large-scale AI models which are typically based on deep learning, being trained on a vast data set. And these can actually be used for any of the disease diagnosis. So it's not specific of diabetic retinopathy or any other disease, but these models are something. And now there is an effort for a global consortium, a global foundation model using images from each ethnicity and using these diffusion models to actually synthesize and have an equal number of each of these images. So these are something which are being done, but as pilots, and now people are trying to use these platforms to build more robust algorithms. As far as future perspectives for AI in diabetic retinopathy has been the predictive health analytics, integrating the data to look into micro and macrovascular complications of diabetes. There are many of these algorithms in silo have been published and people have been using, like to predict anemia, to predict nephropathy, neuropathy, or cardiovascular disease, so that in one retinal image, you get to know about many other micro and macrovascular complications. This was about 2 years back when we worked with Cambridge consultants. We came out with this algorithm to predict diabetic neuropathy. It's important because in India, we do have a lot of foot ulcers, and we approximate have about 100,000 people requiring lower limb amputation. And we could show that with retinal image, we could screen for diabetic neuropathy with a good accuracy. This was the neural network used. And this is the performance. Though it is not as great, but AUC of 0.87, meaning that it's fairly accurate to diagnose diabetic retinopathy. And this was using, the model was trained on patients with no diabetic retinopathy. The other example of similar type of other diseases has been anemia. This again has been work which has been done on SNDreams data set, where we tried using an algorithm which was, you can see, highly accuracy of 98% to say from retinal image whether it is anemia or there is no anemia. It's a binary classification, not the absolute level of hemoglobin. We also went ahead trying to see what exactly the algorithm looks, and it looks into peripapillary area. So we went ahead looking at what at peripapillary area it looks at to identify presence of anemia. And we used image processing. We could find that it's the vessel tortuosity and the vessel thickness it looks and then tells whether a person has anemia or not. These are, as I told you, many of these algorithms are in silo, but ideal would be having all of them together so that a comprehensive diabetic retinopathy screening can be done. Another future perspective has been trying to identify imaging biomarkers for disease like for diabetic macular edema. This was one of the work done by one of our postgraduate student as a thesis. Happy to share that it has also been patented, which looks at algorithm looking at multiple OCT biomarkers for inflammation. So it's a comprehensive score taking in account all the inflammatory markers. So definitely it's a very objective way of scoring inflammatory markers. And we have also done recent studies trying to correlate it with systemic inflammation in the body, because diabetes has a lot of other inflammatory component, and we have shown that this inflammatory scoring is also associated, like you can actually systemic inflammation patients have more of these the OCT based inflammatory score. This is a small video which shows that we can actually put in these images and then run. So it gives an individual biomarker score like severity of hyperreflective foci, location, and hard exudate severity. So all of those, it gives a score to it. And finally, it comes out with a overall inflammatory score. How is it? We have created a threshold to identify responders versus non-responders for diabetic macular edema. So this is something which is definitely futuristic, not only looking at this, but even looking at the other OCT biomarkers. There are a lot of work not only on OCT, but even OCTA. Another perspective is trying to identify newer risk factors, and this was a very recent work which we have done. Retinal age is something which is determined using a AI algorithm. So you can find the age using a retinal image. And if there is a difference between the biological age and retinal age, that's called as a retinal age gap. And there have been a lot of evidence today that this retinal age gap is a risk factor for mortality. Means if this risk age gap is more, that means the chances of early death is there. And there are now at least 2 to 3 very good publications suggesting this is there. We actually looked into in our population that can we find, because Ascent Dreams was a 4-year follow-up and we had many people who died. So we tried looking at can we identify a retinal age using retinal images. We could use one of the algorithm and find out a retinal age. And we also found that it is related to mortality, nearly 2.18 times more risk of death over in 4 years with these patients. But interestingly, we also found that it is an independent risk factor for diabetic retinopathy, the retinal age gap, and especially more for proliferative diabetic retinopathy. So the predicted age was substantially more, nearly 6 years more in cases of proliferative diabetic retinopathy, again suggesting that probably this can be one of the newer marker as a risk factor for diabetic retinopathy. So just to conclude, there are a lot of newer frontiers which are happening in AI field. We have better performance matrices with these to evaluate these algorithms. Every day we get a new case use where AI can play a role. And more we are needing less human intervention. When we did our Google study, I remember it was a huge task labeling lakhs and lakhs of images, but now with the newer techniques, you don't need so much of human intervention and still get a very accurate algorithm. Thank you very much. I'd be happy to take any questions.
Absolutely a brilliant talk, sir, as always. So much to learn from you always.
Well done, Rajiv.
Sir,
Thank you. Yeah, please.
Can I just ask you something on retinal age gap? So what are you looking at? You're only looking at mortality, or you're also looking at disease progression?
So now what we looked into was disease progression. Mortality, already people have looked, and we also looked that it is associated with mortality. So whatever has been published by Dr. Tin Wong group, even from Taylor Rim from Taiwan, they all have published it. We also proved the same thing, that if you take a retinal image and make an algorithm, it will give the age. If that age and biological age are same, that means it is good. But if there is a difference in that, your biological age is less, retinal age is more, That means there is an age gap. And this age gap, they are trying to correlate with mortality. We also correlated it with severity of retinopathy.
The same thing, algorithm is used for the cardiovascular disease also?
No, that's a different one. That gives a calcium score that is again developed by Medivales.
Yes.
And that's a commercially available one. However, we don't use a coronary CT that often. So we don't know, but they have marketed it. It has got a lot of approvals, and that is something which is again there.
Brilliant, sir. Brilliant idea, actually.
Fantastic. Yeah.
Any other comments from any of the panelists?
Rajiv, I think it was a very beautiful, very nice overview of the artificial intelligence. It's already created a lot of waves, and it's going to be the future, in my opinion, the mainstay, as far as not only diabetic retinopathy, even for glaucoma, we're using that huge number, this thing now. But you think that in the future, maybe about 5 years, 10 years from now, the AI will completely replace not only the diagnosis of diabetic retinopathy or glaucoma, or even for that matter, any diagnostics in ophthalmology. We can talk only about ophthalmology here. Yes.
Correct. So it may not replace the diagnostics, but definitely it will become more accurate. Radiology, already it is happening that the diagnosis by a radiologist is comparable to a AI diagnosis in majority of the ways. So the same way it will help us in certain things which our efficacy will actually improve. Our efficiency will improve.
For example, we are using now for biometry for cataracts, the AI-based formulas.
Correct.
Many of the AI, for example, the Hill RBF, the Kane, the EVO formula, many of them are AI-based.
So you won't have much refractive surprises by that, definitely.
But all these, require big data, like what you have told. So
but now that's what now the newer algorithms or newer techniques in AI, they don't need the initial ones where you need a huge data. But now with many of these algorithms, even with the small data, you can work like now this diffusion model, small data, you can make it big by creating synthetic images, which are as good as the primary image, which can be used to, based on the proportions in the population, you can create that.
Yeah. And the AI, you are told that can also predict the progression of the diabetic retinopathy.
Yes.
So what are the markers for that? For example, a patient is coming with a mild NPDR or moderate NPDR. So what is the rate of progression you can predict in this particular?
Yeah, so we can predict. So based on the initial retinal image and the associated metadata, you have to give like HbA1c or duration of diabetes, couple of other things. Very high accuracy, it could predict like what we showed Professor Tin Wong had developed. But these are the ones which are, as I told you, they are not in clinical use yet. But these are the ones which will definitely, it has been validated across 8 countries. And it's working pretty well.
Okay, any other the speakers, any questions, Swapnesh? Yeah.
Just a thought, maybe at the other end of the spectrum, the same retinal age could be used for ROP using the RETCAM images. Could be a thing for future.
Yeah, it should be. Yes, absolutely. We should tell to Parag Shah, who is working by, and Adit Videkar, who are working on the images using RETCAM. Padmaja is there. She can take this. That's a good idea.
Now, how does it work for ROP? I want to know.
He wants to predict the age based on the retinal thing, and how it will be used would be something you have to see, that if there is a difference, means these are the ones, whether they will develop ROP. That's something which we don't know. It's just a speculation.
So it's a brilliant talk. One comment is that as we were having a question that whether AI will replace. So I feel that whenever in real world scenario, when AI models are in use and you tend to have false positive referrals and all more. So sometimes you need to develop a system where you have a trained photographers who can capture the images and also have some semi-automated type of grading capabilities where they will be able to see, for example, if the AI says it is no diabetic retinopathy, it is fine because false negatives are very less. But if it says DR is positive, so a second level of grading also can be done at the moment so that we can
Correct.
reduce the false positive and reduce the burden on the referral system.
Absolutely.
So, and over the time, definitely all these models are going to become better and better. And we all have to be humanized.
Yes.
Thank you.
And also, Raji, you are
Right.
mentioning about one particular this thing scenario wherein diabetic retinopathy, we can we can follow up the patient even after 32 months or something like that, instead of
Yeah.
every 6 months or 1 year.
Correct.
So
That's based on progression. So once if we know that they will not progress, so this is yearly progression chance, it will give us percentage how much chance of progression. So like routinely what we follow is an annual follow-up, but if we know that progression is less, however, we have to give a disclaimer that existing whatever their systemic levels they have to maintain, but then this will you can increase the follow-up to 2 years or 3 years. So SN Dreams patients, when we use this algorithm and we could predict baseline the level of retinopathy which was there, we could say in 4 years what would be their level of retinopathy. And if suppose we could say
already we know, no, we have got some algorithms for that.
yeah.
Simple,
No, we
suppose
have
we
algorithms to say that what is today's status. But what will happen after 4 years is something the AI algorithm could tell. So while training these algorithms, we used both data. And then when we used it for a testing set, which was unseen, very accurately, it could predict whether this person will develop PDR, this will go to severe NPDR. The beauty of that system is it gives all the stages of diabetic retinopathy.
So you can, based on this, you can ask the patient to come in for even for a longer follow-up.
Longer follow-up, yes.
Okay. Fantastic.
Okay. Great inputs as always, and thank you so very much, Dr. Rajiv, for an excellent, insightful talk, I will say. Now we move on from one pioneer to other pioneer who also needs no introduction, none other than our own, I will say, Dr. Padmaja Kumari Rani. I personally had a great pleasure working under her for almost 2 years, extensively on diabetic retinopathy project, and a mentor par excellence, a teacher par excellence, as a surgeon par excellence, as well as a researcher par excellence. And she will be talking to us on what is the current screening scenarios for battle against diabetic retinopathy as far as the real world data goes. So over to you, Dr. Padmaja.
Thank you, Manoj. And I'm actually remembering our beautiful memories of working in SN Dreams together today, along with Rajiv and everyone. And also, thank you, Dr. Mohan Rajan, and all this SN alumni.
Your audio is not very clear, Padmaja.
Oh, am I audible now?
Audio is breaking.
How is it now, sir?
Now better.
Okay. Thank you, everyone, thank you, Manoj, for the kind introduction. Am I audible now clearly?
Yes.
It's better now, Padmaja.
Okay. So I'm actually today.
But I think.
Hello.
No, Manoj. Manoj.
Yes, sir.
No, the Padmaja's connections are not, I think, very good. That's why she's breaking up.
Okay.
She's okay, sir. Dr.
Okay,
Padmaja,
no?
can you hear us?
Yeah, I can hear. Can you hear me?
Yes, we can hear you,
Yes,
and
yeah.
we can see the slides. Please go ahead.
Okay. So let us look at the battle against diabetic retinopathy on the eve of this World Diabetes Day. So we will look at some recent advances other than which already Rajiv has elucidated very clearly in a very nice talk. So, and as we look at the multi-centric study, the Smart India, where we have one part of the group. So in India, we are having diabetes prevalence around 18%, and among them, diabetic retinopathy is around 12%. And we have 3 million people with vision-threatening or sight-threatening diabetic retinopathy in India. And when we look at even a hospital-based study, we found that the prevalences will become much more alarming. We found that almost every fourth person who entered in our network, LV Prasad network, was having diabetic retinopathy among people with diabetes, and among them in a hospital-based area where 50% of them were having sight-threatening diabetic retinopathy. And when we look at the national-wide prevalence of again visual impairment, this is again from Smart India data, where nearly 21.1% of people with diabetes have vision impairment, and you can see blindness is in 2.4%. So based on this, we as a group with Vitreoretinal Society of India and as well as Research Society for Study of Diabetes in India, that is RSSDA. So this is a conglomeration of both physicians and ophthalmologists coming together to form specific guidelines, diabetic retinopathy guidelines for physicians in India. Led by Dr. Manisha and all our team. And this was the main synopsis for the diabetic retinopathy guidelines for physician includes type 1 diabetes, where initial eye examination is recommended, 5 years following diagnosis of type 1 diabetes. Type 2 is required at the time of diagnosis of type 2 diabetes and pregnancy, as well as and whenever you have annual fundus photo screening at physician clinic is recommended. And whenever you find any evidence of diabetic retinopathy or a diabetic macular edema, we need a referral. So it is a position statement giving a very clear-cut guidelines for the physicians. So whenever we propose a classification which should be having a same language between the physicians and an ophthalmologist, and because the physicians are the first point of contact with the people with diabetes, we propose an international clinical diabetic retinopathy classification, which is a much simpler classification, which will based on even a single fundus photograph. One will be able to know whether there is a diabetic normal fundus or just a red dot with a microaneurysm and like a mild NPDR or moderate NPDR, or in all quadrants hemorrhages like severe NPDR. So this classification is much more simple to use, which should be used by both physicians and ophthalmologists. So, and then similarly, a proliferative diabetic retinopathy with high risk characteristics. Similarly, international classification also come up with a diabetic macular edema severity scale, which is like a mild diabetic macular edema, moderate where you are having, this is again a photographic based classification where you see a moderate hard exudate which are approaching the foveal center or involving the foveal center, that is severe diabetic macular edema. So in terms of sight-threatening, diabetic retinopathy will be severe NPDR or proliferative diabetic retinopathy with high-risk characteristics, moderate diabetic macular edema, or severe diabetic macular edema, and any patient with ungradable images. So in terms of advances in the retinal diabetic retinopathy, in terms of investigations, wide-angle OCT angiography has revolutionized, where we are able to have dye-less visualization of both retinal and choroidal vasculature. And similarly, in diabetic retinopathy, it can detect especially the diagnosis and also the extent, and both qualitatively and quantitatively, it can give us an estimate of diabetic retinopathy. So when we looked at in a prospective study, we have clearly found that the patients who have diagnosed as a moderate non-proliferative diabetic retinopathy on wide field fundus photography, we have been found that at least third of them, that is 33% of them, were actually found to have NVEs, that is proliferative diabetic retinopathy on wide angle OCTA, because it can detect even the subtle neovascularization elsewhere as well as on the disc. And when you look at this fundus picture, it might look like maybe we might suspect some early PDR or some new vessels. In the left eye, it is, you can say small exudates are there and some severe NPDR. But when we actually do a wide angle OCTA for the same patient, you can look at the amount of neovascularization, where on octa based, it can actually phenotypically will tell us how much severe proliferative diabetic retinopathy we are dealing with. So you can see in this octa-based pictures, we clearly show a CFAN type of neovascularization, a tree octopus type of neovascularization, or a tree type of neovascularization, and as well as IRMAs. And this has investigation has not only as an utility in terms of diagnosing the severity of the proliferative diabetic retinopathy that we are dealing, and also it is an excellent follow-up tool in terms of showing the regression of the neovascularization after laser treatments or after our treatment interventions as a follow-up tool. In looking at the medical management advances, anti-VEGF agents have revolutionized the treatment of diabetic macular edema. But however, whenever we look at a diabetic macular edema management, one should not forget two S, that is systemic control, and as well as steroids sometimes whenever there is a refractory diabetic macular edema. So, and these are all the various drugs that have revolutionized in terms of medical management of diabetic macular edema. And but one should never forget that the systemic control is the cornerstone, and that is where the physician and ophthalmologist collaboration is essential. For example, whenever a diabetic patient with a diabetic macular edema walks in my clinic, the first investigation that I will ask, along with ocular investigations, is actually the diabetic profile. So the diabetic profile contains the fasting blood sugar and the HbA1c and also hemoglobin and lipid profile and their blood pressure. So this is, for example, a patient with a pre-systemic control. It was the diabetic macular edema, and when he had all these parameters controlled within a month, you can see the amount of, this was without any introduction of anti-VEGF agent as a first go. So this is, you can just see that with the systemic control alone, you can see the amount of control of the achievement of the diabetic macular edema. So this is very important to stress to our patients that the systemic control along with the anti-VEGF injections only can give us the ultimate results. And this is again another case of importance showing systemic control. This is a patient whom again diabetic, she was a software professional who came with tractional detachment involving the macula, and she went on to a nutritional intervention under internet supervision, and we have actually found that her diabetic tractional detachment was actually reversed in terms of using these diabetic interventions. So these all interventions one should keep in mind, and systemic control should be kept in mind, and of course everything is the internist supervision. And diabetic retinopathy in terms of surgical management, so all of us are here on the in terms of World Diabetes Day, in terms of creating awareness, and this is the fundus picture which belongs to a forensic medicine professional who is a type 1 diabetes. So you can imagine the amount of awareness that we need to create among our stakeholders, and this is the in terms of advances, microsurgical techniques, where our systems, vitrectomy systems have revolutionized the way we actually manage these detachments, and anti-VEGFs as an adjuvant to the prior to the surgery to reduce the vascularity of the retinal detachment and to achieve good anatomical outcomes. In terms of functional outcomes, we may not get the same thing. That is why the prevention is better than the cure, and it's very important that we need to stress this point to our patients, that the once we reach in advanced stages, we may not be able to, we might get an anatomical outcome, but the functional outcomes may not be satisfactory. So, and that's why again, the coming back again to the systemic management. So we do have the recent diabetic anti-diabetic drugs like semaglutide. They're actually showing, we are a part of the multicentric trial where to show whether what is the effect on the diabetic retinopathy. Similarly, in hypertension is again a very important risk factor which can have a significant effect on diabetic retinopathy progression. So one should make sure that the diabetic blood pressure control should be always should be there, because the blood pressure control will not have any metabolic memory, whereas diabetic retinopathy will depend on the metabolic memory of your glucose control. So the cells remember the glucose. So the initial sugar, the diabetes control is very important to prevent complications later on. Similarly, the drugs like fenofibrate, anti-lipid drugs, which actually can reduce the progression of diabetic retinopathy, even the laser treatment endpoints. And these have not only due to, they can even work with the patients with less normal lipid values as well, due to their other aspects of phenolphlebrate. And anemia, as Rajiv already mentioned, again, it can increase the risk of diabetic retinopathy progression. So this is again another aspect that one should keep it in mind. And diabetic retinopathy and obesity itself can increase the insulin resistance, and this also can be an independent risk factor for DR progression. So these all factors one should keep in mind. So physician-led model is the way forward in diabetic retinopathy management, since they are the first point of contact. Only 5 to 10% of diabetic retinopathy is actually sight-threatening or referable, whereas 90 to 95% of DR management is actually a modifiable risk factor modulation by the internist. So diabetes, hypertension, dyslipidemia control, lifestyle changes, key person will be the internist. And diabetic retinopathy is an image-based diagnosis, and identifying DR by the fundus photography is not a robotic science. With the conglomeration of AI and humanized interventions, it's possible to achieve this effect. Options of cost-effective non-mydriatic fundus cameras are available, and fundus imaging should be part of various battery of investigations offered at the internist or physician office. And this is a definite return of investment with great social impact in reducing blindness due to diabetic retinopathy. So we have a current ongoing ICMR funded project which we call Smart Drop. Smart Drop means artificial intelligence enabled referral pathways for early diagnosis of complications arising from diabetes. And we are actually linking physician clinics in twin cities of Hyderabad with eye clinic through this AI modulation. And these are the factors that will help to bridge the gap and break the barriers, as Rajiv has introduced in his earlier talk. And this is my last slide. So this is the Dr. Nazi Alamuddin, who came to LV Prasad for short internist observation in diabetic retinopathy. He is a physician himself who has been trained in diabetic retinopathy certification, as well as, and these are the kind of integrated models are necessary to prevent diabetic retinopathy blindness so that all may see. Thank you.
Thank you so very much, Dr. Padmaja, for a wonderful talk.
Wonderful talk.
Covering the entire spectrum of screening to importance of early intervention. Any comments from the panelists?
Padmaja, I think is really an awesome talk, I would say. You covered each and every aspect of diabetic retinopathy and how important it is to have the systemic control. But where I was a little surprised and also amazed to see one slide wherein a keto diet can completely reverse even a TRD.
Yes.
Last time I'm seeing something like that in my this thing. How is it possible?
So even I was actually wondering, because in fact this is the when she was a educated person and who came to me with the, and I actually advised her for surgery, and then she lost for follow-up, and after 6 months she called me, and I was just expecting that I will be actually seeing blindness in both the eyes. And but her blood sugars were used to be very high. She used to take 80 units of insulin before this intervention, and her blood sugars were very labile, blood pressure was there. And then we had all the pictures and all the documentation before. And then when she was coming, I was actually worried. And then when I came, and it was such a surprise, because she is now not taking her, she has actually come back. It's called diabetic reversal. So she is not taking any insulin or anything now. And her blood sugars and everything has become, HbA1c has become 5.5. And surprisingly, I saw that in the eye you have. But very important that in this case report, normally the case reports will be usually 1,000 words. But this went for review with a lot of internists in BMJ case reports. And it is actually 2,500 words case report, which actually detects what are all the careful. There are a lot of trials are there related to keto diet, how, and also low carb diets, how it can prevent, or also it can have, how it can have impact on complications of diabetes, not only in retinopathy but also in cardiac and as well as nephrology related conditions. Lot of trials are there, but it is very important that these kind of interventions should be done under the supervision of the internist as well as the physician. It is not something we should not take it lightly.
What about bariatric surgery?
The bariatric surgery is again another intervention where even the renal transplant patients also we do see, and Rajiv has a lot of literature related to that. We have and Rupak also, I think, in this. Yeah, we had that literature. So where it is very shown very clearly that when you have a diabetes control, and many of the complications of diabetic retinopathy show a dramatic improvement. So the patient who comes with a lot of hard exudates in the macula and everything, and we see that after a bariatric treatment, I have seen 1 or 2 cases, this thing where you can actually see that everything has, it looks like a normal fundus, but it happens.
It happens.
So that again shows that we
First
are
time
only,
it happens in X-rays and other things, but
Yes.
first time I'm
TRD.
seeing a reversal
Yes.
of TRD.
Absolutely.
Again, theoretically, TRD reversal, I would say, is because of probably she was be doing some Kapalbhati, some Valsalva maneuver, and vitreous got detached. Because
Yeah, but
reversal
that
of
is,
TRD is very, but yes,
Yeah.
stages of retinopathy, what you have told, definitely reverses.
Yes.
But TRD is more of a physical phenomena where you have the vitreous which is pulling, and
Correct.
that sometimes ERM spontaneously gets released.
Yeah.
It is something like that which happened probably for TRD.
What
But
happened
important thing to realize is that though they work on a long term, but there is a term which is used as early worsening of diabetic retinopathy. So whenever a keto diet or a bariatric surgery is done, there will be a sudden reduction of glucose or glycemic control, which can worsen retinopathy. So these cases who are on keto diet or on bariatric, it's important to evaluate them very early. Because if they are on the cusp like moderate or severe NPDR, they will become PDR.
Yes.
So there is
So-
something called as early worsening. You need to look into that.
Yes, I would agree in this patient. Actually, I have now 5 years follow-up, and I would say that very rarely we see in diabetic patients like that, PVD occurring and then release of the detachment.
I know it is
That
rarely.
doesn't happen
only
so common, but it is a
yeah.
possibility. But what happened is other eye also had a diabetic macular edema, which also resolved. So overall, she had a good positive effect on diabetic retinopathy,
Correct.
along with this kind of dietary intervention.
Correct.
Fantastic. Really an eye opener. Yeah, very nice. Any other
So
comments?
always, so much of calling, listening to.
Yeah, he has suddenly gone off.
Yes.
So I think we can have Swapnesh
Manoj is
talking about the next talk. Swapnesh, you can share.
What about the Manoj?
I don't, yes, come back.
Yeah,
Huh?
Manoj.
Yeah, Swapnesh can.
Sorry, I lost my.
Yeah,
Manoj,
that's why I thought.
introduce my
No, no.
Swapnesh.
Yes, sir. Hello.
Yeah,
Yeah.
please.
Go ahead, Manoj.
Yes, sir. So sorry, I lost my connection in between. So let's move on to the next speaker, a young dynamic retinologist from Amchi City, Mumbai, a very dear friend, none other than Dr. Swapnesh Sawant, a brilliant surgeon, and his surgical videos are a treat to watch. And let's see what he has up his sleeves to share with us. Over to you, Dr. Swapnesh.
So thank you, SN alumni and Manoj for sending this invite, and warm regards to Mohan Rajan sir and RRN sir. It is really a pleasure to speak in front of the SN faculty. So the talk is regarding PDR management, surgical, and few mistakes to avoid. So challenges in the PDR case is usually the complex vitreoretinal interface, the ischemic process. We need to control the hemostasis. We need to be aware of the other eye status. And as Padmadaya madam had told, that there should be realistic expectations both for the doctor as well as for the patient about what would be the outcome of the case. So the typical places where mistakes can occur is not having a very good media clarity, management of the vitreous, hemostasis, management of the ischemia, and the internal limiting membrane. So straight away jumping on to a case, there should be a very good pre-op evaluation, especially if there is a B scan required, that should be done by the operating surgeon a day prior to the surgery. So coming to the first case, typically speaking about the media clarity, we should have a very good media clarity before we start the case. The cornea should be examined thoroughly. if there is any PCO, that should be taken care of. And when the infusion cannula has been put, we should ensure that it is there in the vitreous cavity. And if it is not there, then with your left hand, you can use the irrigation cannula and perform an anterior vitrectomy till we see the irrigation cannula inside, and then only proceed further with the vitrectomy. Now, the first aim of the vitrectomy is to finish off the vitrectomy near the ports, cover the pore vitrectomy, and then try and find an opening in the posterior hyaloid face. So once you see that opening in the posterior hyaloid face, and as you can see in the video, that then things get more easier, that you are in the exact plane. As we all know that there could be vitreous crisis, but if we get to this plane, then further dissection becomes much easier. And if there is a subhyaloid hemorrhage, then that can be, with the help of the suction, that can be taken out, and then we proceed ahead with the further dissection. There are a few other videos, so we'll quickly move on to the next video. And again, the basics being the same. In the last case, there was PVD which was there, but we are not lucky in all cases. And sometimes, in spite of the laser being done, there could be still no PVD in our case. So in this particular case, I proceed ahead with the pore vitrectomy, and then I have to induce the PVD. Usually, we need to leave behind a good amount of vitreous before we approach the disc for inducing the PVD. And if we are too hasty in removing that posterior vitreous, then we will not be able to get a good hold. In fact, the blood that is there, it allows us to identify the PVD and the vitreous face. And once we have lifted that, the movement of the blood itself shows us that we are in the correct plane and we are lifting it up. While lifting it up also, the movement should be gentle, because there could be a sitting NVE which can suddenly start bleeding. And once it is induced with the water currents itself, the further PVD will be taken up. And then proceeding in each and every quadrant, we can start the dissection. So this was about the PVD induction. About the handling of the ischemia. Now, as you can see that a lot of retina has been already lasered, but once we are very sure that the vitreous has been removed, we should proceed ahead with a fill-in PRP. The endo laser that is to be done has to be thorough, because now we are inside the vitreous cavity and we don't want to leave anything for the post-surgery treatment. So especially the anterior areas, because if we leave behind these, this could be potential areas of ischemia which can lead to recurrent diabetic macular edema later on, and also can lead to anterior hyaloid proliferation in very severe cases. So this should be taken care of, and a very good thorough fill-in PRP should be done if it is already not lasered. So finishing this particular video, once all the laser has been complete, that bit amount of pre-retinal heme will get absorbed, and I close the case with a fluid gas exchange. Coming to more difficult cases, so this was a case where, especially if the laser is also important pre-surgery, and also in the other eye. So as the patient is getting his fitness ready, you can take that chance to do a bit of PRP. So this was a case where you can see a lot of retina. So when you see a lot of retina, be sure that it is going to be a tough case. Now, one of the mistakes that I have done is to use too much of tripod, which made my PVD induction tougher. So I was trying to get a hold of the vitreous with the help of cutter, forceps, but nothing was working. And this was like a tabletop PHF, and the configuration actually then made me realize that I better use some other instrument to get the PVD started. So a very humble instrument that is called as PIC. It's just a 24-number needle mounted on the flute, and it is used to dissect. So as you can see, just to create that cleavage plane, but you should be very sure there is no underlying TRD. So proceed very slowly, and once you get this cleavage plane with the help of the cutter itself, then you can kind of start the dissection. Use the suction, as well as suction is mainly used to remove those IVTA crystals, and then with the cut and proceed technique, desegmentation is done, and the port optimization with the modern cutters really helps us to really get in the correct plane and feed that PHF in the mouth of the cutter. It is also very important to be ambidextrous. Now, as you can see, I'm using my left hand to dissect a very odd area, especially the nasal areas. So that should be kept in mind. Above the disc, the PVD has to be loosened very, very gently. I'm using forceps to do that. And then proceeding with the desegmentation along the horizontal midline on both the sides. So lift and cut is the methodology that I follow. Lift the vitreous and then cut it ahead. And beware of the retina below, because you can suddenly induce traction and cause a lot of bleeding. So and you have to be aware of which quadrants you have already dissected. Here we are seeing a very thick stock of FVP being there, and there is going to be some risk of bleeding, and to my fear, and it just started oozing. So immediately raise the bottle height and just wait there. Most of the times, if you just wait it out for 2-3 minutes, the bleeding stops. Unfortunately, some blood went in the subretinal space, but largely it was controlled. And then with slow suction, I was able to dissect out the pre-retinal part. Don't forget that I have the nasal area has to be dissected, because once you have an event like this, you just want to close the case. So be aware of which all quadrants the vitreous is still to be dissected, and proceed in the plane of dissection. Extend it as far as possible beyond the posterior pole. Use an endocautery to mark your breaks. Again, complete the case with a fill-in endo laser. And I think I have a post-op picture of this particular patient who did quite well. Going on to the last case, this was again a case where there was a large blob of pre-retinal heme which was sitting. And after the typical anterior as well as the core vitrectomy, I decided to tackle that particular area directly, because it was just ballooning up. So I was pretty sure that once I get into the plane of PHF, the the pre-retinal blood is going to just start coming in the cutter itself. And it beautifully just came out. And it's not always a plan to induce PVD only over the disc. In such cases, you use this particular advantage, and because the pre-retinal blood has already come out, you already know that there is the plane where there is no vitreous chiasis below it, and you can use this particular plane then to further dissect the PVD in the other quadrants. One thing I do usually is, if I know that there are few sets of FVPs which I have to tackle in other quadrants where I am very sure that the vitreous has been dissected, I use that opportunity to finish the sector laser in that particular quadrant. Because if, God forbid, if there is a large bleed, then I have missed that chance to do the laser. So before tackling a difficult area of FVP, and if I am very sure that the vitreous dissection is good, I complete the sector laser or a partial PRP and then approach that FVP, because as you can see, this is a very broad base FVP and it will require a lot of maneuvering and dissection. And I'm usually going to use an endocautery cutter as well as forceps to cut the bridging tractions. And usually I use the endocautery in such a way that I am cauterizing inside the FVP so that the edges curl on themselves, which gives us a plane between the FVP and the retina, through which the mouth of the cutter can go in. So there can be always an argument that bimanual dissection could be done, but I am more comfortable doing like this. But definitely bimanual also could be performed in these cases. Very important to maintain the hemostasis and beware of your bottle height when you're doing all these maneuvers. Now there could be a mistake over here of yanking out this particular area completely, but just lift it up and observe what lies below, do the trimming of the FVP and then proceed further. So we have to be very patient in doing all these cases, and you are going to face sometimes an area where there is going to be bleeding. But yeah, if you are dissecting, if your visualization is good, and if you just have a bit of patience, you will get out of this sticky situation. And sometimes you can leave that area if it is not coming out. If you feel by dissecting it out it is going to create a large retinal break, then, and if it is not causing any traction over the central area, you can just leave it there. Now, one more mistake that I have done over here is you can see those striation lines which are stained by the blood. This would have been an ideal case to actually do a bit of ILM peeling if it was possible. This particular patient actually did well. After 6 months, he required a ERM removal. But overall, for this part, for the PDR part, it got stabilized after the surgery. I have a post-op picture also of this patient. But if now retrospectively, if I see those striations, and it would have been a great idea to actually do at least attempt an ILM peeling if it was possible to be done at that particular time only. So I'll just end this video and we'll see the post-op picture. So that particular tuft was quite difficult to be dissected. This was at the closure and looked pretty okay. And this was the post-op image. Anti-VEGFs definitely are an armamentarium in our with us to tackle the ischemia. It reduces the surgical time. It also reduces the intra-op bleeding, but it has a questionable role in post-operative rebleeds, and some say that it may worsen the ischemia. But I definitely use it 3 to 4 days prior to these surgeries. So thank you very much. And thank you again, SN Alumni family, to give me this opportunity. It was a pleasure.
Thank you, Sapnesh, for taking us through a video-based course of vitrectomy surgeries for high-risk proliferative diabetic retinopathy patients. Any comments from the panel on these videos?
Sapnesh, can you just stop sharing the screen? We can see each other. Yeah. Sapnesh, really wonderful videos. Fantastic the way you handle. So all the patients you give preoperative Avastin or whatever it is.
So high-risk PDRs, definitely.
All the cases you give. And the PVD induction, I think it was a master class, how you induce the PVD, especially when this lasered PRP eyes, so difficult to induce the PVD because it's stuck everywhere. So I think it's really fantastic way of demonstrating that. Really learned a lot. Yeah, Sapnesh, yeah.
I think excellent surgical videos and so one point, as you said, ILM peeling. So my favorite is actually also to inject brilliant blue whenever we have, especially arcades when there are proliferation. So on the backdrop, you'll be able to remove the cortical vitreous tentacles over, because the brilliant blue stains both cortical vitreous as well as ILM. So we'll be able to actually get a very nice cleavage.
Thank you.
I could add a couple of points. One is that the media clarity has to be ensured. So if there is a cataract, I separate the procedures. I do cataract surgery first, let the cornea settle, and then do the retina surgery after a couple of weeks. Second thing is that if there is a very dense vitreous hemorrhage, organized vitreous hemorrhage, and if you have you can pretty much do half your core vitrectomy with AC maintainer also. So if you are worried that you go subretinal, you can go subretinal while putting the cannula. You can do a core vitrectomy and clear the central and anterior vitreous with AC maintainer also. That is something that I have used in such chronic vitreous hemorrhages. Third thing is, if you do end up with a break in diabetic patients, I think you can use after you have removed complete traction, you can use fibrin glue as well to kind of as a and then get away by doing just fluid air exchange, and you have to laser around it. And then fibrin glue can be used. I've used it in a couple of patients like that. But we have to be sure that the vitreous traction is removed very well. Vitreoretinal traction, I mean.
Very nice.
So very valid points, Manish sir. For the dense vitreous hemorrhage, usually what I do is I take that visco cannula and try and straighten it and attach it to the tubing and put it through the left-hand port and do the anterior dissection. So instead of the AC maintainer creating one more entry in the cornea, that is what I do till the anterior vitreous and the core vitreous is clear, and in between keep checking whether the irrigation cannula is seen. The moment the irrigation cannula is seen, then we start our routine with the light bulb.
I think we used to do something like this with butterfly needle, no? I remember in
Butterfly
the
needle,
earliest days. Yeah, yeah.
butterfly needle.
Yes,
Especially
yes,
in that Venugopal OT, end
yes,
of
yes,
all
yes.
butterfly needle will go inside
Yeah.
first.
Suddenly I went into that place.
So,
Very
so this AC maintainer thing is useful in traumatic chronic organized
absolutely.
hemorrhages.
Indeed.
It's useful in end-offs
Endophthalmitis.
where
And
there is
AC maintainer,
Standard.
we were not using in SN, but when I came to LVP, I was started using, and it is very good. Even in phakic eye, you would need not,
yeah,
you won't touch
exactly,
lungs.
exactly.
And
You won't touch
Correct,
the
nowadays you
lens.
can even put a trocar ACM. You don't have to
Yeah,
have a
yes,
regular.
yes.
correct.
You know,
Trocar
you won't
ACM
touch
works.
the lens. Yes,
The trocar ACM works very well actually. 25 gauge works very well.
yes.
Yeah.
Okay, I think in interest of time, let's move on to other stalwart
Very
from
nice, Sapnesh.
Sapnesh.
Fantastic.
Brilliant, Sapnesh, always.
Yes, yes.
Move on to the other a brilliant surgeon friend, very close friend, Dr. Manish Bapaye from Nasik, and he has won many surgical video awards. And it's always a treat to watch Manish's videos and learn a lot from there. Over to you, Manish, for your today evening presentation.
Before I share my screen, I think what presentation Rajiv Raman did, it is almost like a sci-fi, and it took me back to SN days where where there used to be meetings on angiogenesis and where they were discussing anti-VEGFs, the trials at the beginning of the whole thing, and here we are injecting injecting anti-VEGF every day, thousands or lakhs of them. So I think in another 5-10 years, this is going to be a tool which is going to be we will be using extensively in our clinics with large language models and all these things coming in. So I'll be presenting only one case. I'll just share my screen. Yeah. Can you see this thing?
Yeah, it's visible
Yeah,
and
yeah.
your audio.
Okay. So this was a patient who had, he was a one-eyed patient. He had this, proliferative tissue over macular area. His vision was 6/12, pseudophakic, and at presentation, this was his clinical picture, and this was the OCT which was there. We can see very angry looking fibrovascular proliferation, which was there over the over the macular area, and the NVD was there. So at this point, I did panretinal photocoagulation. And after panretinal photocoagulation, as we can see, the angry look of the proliferation reduced, and the patient's vision stabilized, and even the macula, the TRD which was there, had kind of settled. So I didn't have to intervene. This was for 3 months post PRP. But 9 months after PRP, he came with a drop in visual acuity, and this was the 6/36 vision which is there, and he had this active vitreomacular traction with thick fibrovascular prolif or posterior pole and the macular area. And so the surgical intervention was required. And as we can see, the proliferative tissue was mainly over the disc area and the macular area. So it was very tricky. There was a frond in the infratemporal part as well, but this was a very tricky case because it was not a very well dilating pupil. The proliferation was mostly in the papillomacular bundle and the macular area, and any iatrogenic touch to the retina would have been disastrous when we knew that the patient had good visual potential. So intraoperatively, after doing the core vitrectomy, obviously there was no PVD which was there. So initial opening was made in the posterior hyaloid, thick posterior hyaloid in the close to the disc in the supratemporal quadrant, and then I started segmenting the membranes in this in the supratemporal quadrant. So this had to be again, as Swapnesh has shown, it has been only cutter has been used. The thing I thought what was very important to remember was at there, there is a, you are tempted to just pull the vitreous, just pull the fibrovascular tissue, because then it can, when you can get a good hold over it, but that can lead to disastrous complications. So here I was trying to do the carpet rolling over the disc area, but it wasn't very useful. So I went back to segmenting the membrane. Then it was segmented in the PMB area, papillomacular bundle area, and then went around dissecting the optic nerve and on the nasal side. We can see the vitreous getting separated. As the vitreous separated, uh, then it separated over the macular area also. Luckily for me, there was no nail, fibrovascular nail in the perifoveal or at the fovea or perifoveal region. Otherwise, at this point, it could have led to retinal break at the macula or macular hole. So then this was adherent, or it was all connected to the fibrovascular front, which was there in inferotemporal quadrant also. And at this place, I started doing the carpet rolling maneuver, whereby we are using the cutter so that in a way that the fibrovascular membrane keeps rolling into the cutter port. As Swapnesh said, the port optimization works beautifully well, and there is no hard and fast rule that we can do only one technique. We can do, multiple techniques, the combination of techniques, so as to get proper dissection between the membrane and the retina. This was the tissue in the inferotemporal quadrant. We can see it was well lasered. I had already done the PRP about 8-9 months back. So there wasn't much area left to laser. It was well lasered. Only and because of that, probably the membranes are also not as vascular, not as angry. Of course, the anti-VEGF was given 3 days or 4 days before the surgery. Here again, this is a very tight adherent area in the inferotemporal quadrant. So there was this small ooze which was there, but fortunately for me and for the patient, there was no break that developed. So we can see we can use this cutter tip itself to give compression. So as we can see, 1 month post-operatively, the patient had there was a cut proliferative tissue over the disc, and the macula had settled. The patient is with me for following up at regular intervals, and he still maintains 6/9 part vision and is able to do his job quite well. His sugars are also well controlled. So I think using combination of techniques in such patients is quite useful. So this was just one case that I thought I would present. Thank you for opportunity. Manoj, thanks a lot for giving.
Thank you, Manish, for showing us an excellent case and also telling us the importance of when to intervene, how to intervene, and how safe to play as well.
I have a question, Manish.
Yes, sir.
Manish, very nice presentation, Manish. Manish?
Yes, sir.
Yes, sir. Go ahead.
Very nice presentation.
Thank you, sir.
What is the reason? Is the PRP responsible for the traction to increase?
So I think as you do the PRP, the proliferation kind of shrinks, and that itself causes increase in traction. So that is something. But the point is, if we do PRP beforehand, we have to be prepared mentally to intervene surgically in such patients. We have to explain to the patient that this is not going to be. I mean, I could extend the surgery for 9 months in this particular patient, but as soon as the PRP is done, as the fibrovascular tissue contracts, it can cause TRD. The vision can drop in such patients immediately after laser. So this has to be explained to the patient. But doing PRP would help us in intraoperatively also, as the proliferative tissue is less angry and less vascular. It reduces the chances of intraoperative hemorrhage.
Okay.
This patient looked like a natural progression of the disease, actually, more so.
That,
You know,
yes.
Yeah, natural. And also the importance of dissecting the membrane with the help of a cutter. You showed it quite beautifully.
Yeah.
Any further comments from Dr. Padmaja?
What you do? Use a 25 or a 23? 25.
So I use 25 for
25.
cases.
Okay.
Yes.
Only thing I would have added as Dr. Padmaja's technique, which we have learned from over years, staining with brilliant blue in these cases, not with
Yeah.
tricot. Even to stain vitreous, I'm using brilliant blue only nowadays. It stains quite beautifully well and also gives you the advantage of dissecting the vitreoscatic membranes. So, you know, yeah.
It's
In fact,
helpful both in
I
diabetes
also
as
stained
well
it
as
couple of
pediatric.
times.
Pediatric detachments also it is helpful.
Pediatric
So
detachment also.
Manisha, I think excellent surgery and it's nice to see all of you again. I think the flat bleeders, right? So it is also good that instead of diathermy, we can actually use the endolaser probe using continuous mode. It actually works beautifully, especially the flat bleeders, so that we can avoid cautery marks and potential breaks in future.
So LG sir has also taught us to use the cutter tip, just
Yes,
as a
yes,
pressure.
yes, yes.
That also can be used for
Yeah.
what?
But the way you dissected beautifully with a cutter, it was very nice.
Yes.
And
Thank you, sir.
very
Thank
nice.
you.
Beautiful. Very nicely done.
Excellent video, Manisha. Thank you
Any
so
other
very much.
comments? Any other
Yes,
comments from anybody? Swapnesh?
Continuous laser mode was favorite of RRN, sir. We have learned it from him.
Yeah. That is Tarunji's TSRs. All chelas will do continuous mode. We also have Rupak there.
Yes. So I think let's move on to
How do you determine the
last.
power in a continuous mode? How do you know whether it's not too high or continuous mode?
You get with experience, you know that you have to move quickly. You cannot be at one place for a
Yes.
long time.
Means I use continuous mode mainly for the barrage, not for the PRP. But
PRP usually we don't use continuous. I agree with
yeah,
you, but
yeah,
all others, especially if you have a break, you want to cover it.
yes. And the
Definitely.
advantage is
No,
with
great
less
video,
power itself.
Manish.
Advantage is
Great
with
video.
less power itself, we can get good burns actually.
Burns. Okay.
Thank you, Dr. Raju. Thanks. Thanks, sir.
Only thing is, I usually, though you started from posterior pole, truncation is important. I'm sure you would have done because that helps. And even if there is no PVD, I usually keep a very high suction and do a truncation so that I can come from outside in rather than from inside out.
Yes.
That's how
Yes.
usually I do. But
Yeah.
yes, this case it worked because you didn't had any other plane, but that was a plane which you could get very easily. But in
Yeah.
diabetic vitrectomies, I think truncation forms a very important step.
Yeah, so I think we have to be, we cannot be dogmatic in these
I
cases.
agree.
Wherever we can start,
I agree with
wherever
you.
we can get a separation between vitreous and retina in a safe manner, we should, inside out, outside in.
agree.
There are many cases where the peripheral PVD is little bit present, and there we can come outside in as well.
Only
So
thing why your pre-op picture showed a large subhyaloid heme also
no,
temporally.
there was no
No,
subhyaloid
no,
image.
or it was just there was
It was
because
just a very angry
intraoperatively it was
looking
looking.
fibrovascular,
You know,
I
angry
thought that
looking NVD.
NVD. It was NVD.
correct.
Yeah.
And I thought temporarily it was a big subhyaloid.
Subhyaloid heme. That's what your
No,
color
no,
fundus
The
picture was
picture was
very
yeah.
deceptive, and I was thinking you will start from there. You went in, it was very clean. Only the disc thing was there.
Yes.
No, there was no subhyaloid image. It was very
Correct.
angry looking NVD which was there.
Sure.
They would have misdiagnosed it.
That-
With the talking about the physician referrals, I think AI would be very helpful.
Absolutely true.
As they say, hopefully artificial intelligence will come over, natural stupidity. So let's hope we see patients early.
Okay, let's move on to the next star of the evening. None other than another dear friend from Kolkata, Dr. Rupak Roy. To introduce Rupak, I will be falling short of words if I say one of the brilliant minds in ophthalmology research. And also, he is the person who will be always with a question. You cannot meet Rupak any day without a question in his mind. And openly he will be asking everyone around like how we are going to do this or can we innovate something better. His contribution to multimodal imaging is par excellence. And over to you, Rupak, for your presentation for today evening. You're muted, Rupak.
Yeah, thank you, Manoj, and thank you, Dr. Mohan Rajan, for this opportunity. I know we are late. After this wonderful talks, my talk is very simple and I'll try to keep it very short.
No, you take your time, Rupak. No problem. Take your
We have time.
Yeah. So, is my slides visible?
Yes.
So basically, my talk is very simple. I'll be speaking about management of diabetic retinopathy in the setting of a significant cataract. So basically, what to do from so what would be the advice from a retina surgeon's perspective to a cataract surgeon when a cataract surgeon is planning cataract surgery in a patient who has cataract, significant cataract, and also has diabetic retinopathy or diabetes. So cataract surgery in a patient with diabetic retinopathy. This is a basic, simple presentation, and it's basically a presentation on a case-based scenario rather than a lot of didactic stuff. So the main challenges that we face in this scenario are basically the retinopathy progression, the progression of the maculopathy, and the complications. So the broad guidelines basically have not evolved. That is, basically you treat macular edema before you start cataract surgery or plan a cataract surgery. You, if the patient has a PDR, you try to complete pan-retinal photocoagulation before you embark on cataract surgery, and you achieve optimal systemic control. But sometimes you are faced with a situation, patient has a significant cataract and there is a macular edema, and you have to treat. So studies have shown that macular edema after cataract surgery in eyes without preoperative central involved macular edema, there is an increased risk of developing macular edema in this patient. There is a 10% increased risk. And also it has been noted that patients, just one second, is my slides moving?
It's okay.
Just one second.
Change over to the next slide.
Yeah, just give me 1 second. It's not moving. Yeah. So also it has been seen that the risk of pseudophakic macular edema is also more in patients with diabetes, the patients undergoing cataract surgery. Before embarking on a cataract surgery, it has been recognized that OCT should be done in all cases of patients with diabetes, even if you don't suspect macular edema in a patient whom you are planning to do cataract surgery, because studies have conclusively proven that around 30% of cases, a clinical examination can miss diabetic macular edema. So now we'll run through a few scenarios. The first scenario that comes to our mind is a patient has a cataract. The patient is diabetic, but there is no retinopathy. The standard recommendation in these cases would be to start the patient with topical lepafenac eye drops for 60 days after the cataract surgery. This should be continued. This has shown to significantly reduce the incidence of developing macular edema after the cataract surgery has been done. Now, the second situation is the patient has a cataract and there is a retinopathy, but there is no diabetic macular edema when the surgery was done. In this patients, the prophylactic nepafenac therapy should be done. And what we do in all these patients is that even after at the GA visit or after 1 month of the cataract surgery, we end up doing an OCT because these patients have a very high risk of developing macular edema post-cataract surgery to assess if there is any development of macular edema. If the macular edema develops, we treat them accordingly. Now, scenario 3 is quite common when the patient has a significant cataract and there is a center involving diabetic macular edema where you have to treat the cataract and also take care of the macular edema at the same time. So there are 3 alternatives that we really have. One is treat the patient pre-operative with the anti-VEGF. Then after 2 weeks, sort of plan the cataract surgery, do a combined cataract surgery and some sort of intravitreal pharmacotherapy, or do a cataract surgery and then plan some sort of intravitreal pharmacotherapy after 2 weeks. But when you are faced with a significant cataract and a macular edema, probably the most effective approach that most of the surgeons nowadays take is do a combined intravitreal pharmacotherapy with cataract surgery. And the most commonly recommended treatment is cataract surgery with an anti-VEGF agent. That is the most commonly recommended agent. So now we have really lot of agents in our hand, like ranibizumab, aflibercept, faricimab, and a host of biosimilars. Which one to choose is really a big question. Various studies have shown that if there is a good vision, there is not a lot of difference between various anti-VEGF agents. But if the patient has a poor vision, aflibercept may be a drug of choice. My take on this is whenever we choose an anti-VEGF therapy, we should really be looking at the efficacy of the agent, durability of the agent. We should be remembering that agents like ranibizumab has an efficacy of around a month. Aflibercept has an efficacy of around 2 months. And the faricimab, the promised efficacy of is around 4 months, though we now know that it will last around, say, 2 to 3 months. And of course, the paramount importance is for our practice and for our patients is the safety of the agent, because a lot of biosimilars are floating around. So before you inject any biosimilar, you should be sure about the safety label of the biosimilar before you put that into your patient's eye. Scenario 4 is a cataract surgery patient who has already received multiple anti-VEGF agents, and you know the patient is refractory DME. This patients, you can consider switching the anti-VEGF. Say, for example, patients were receiving a lot of ranibizumab. You can consider putting the patients doing cataract surgery with a different anti-VEGF like aflibercept or a faricimab. Or you can combine the cataract surgery with a steroidal agent like a triamcinolone acetonide or Ozurdex. Nowadays, probably Ozurdex is the most commonly preferred agent. Multiple studies have preferred Ozurdex because of its longer duration of action, lesser IOP spikes, and one of the most brilliant advantages of Ozurdex is that it can be given to patients with glaucoma, that is patients who have stable glaucoma with the patients who have a stable glaucoma with a single anti-glaucoma agent. Scenario 5 is a patient with a cataract with proliferative diabetic retinopathy, where you have done an ultrasound and you see there is no traction, but the view is not good for you to do a laser. In this situation, what we do is we advise a cataract surgery with the anti-VEGF agent and counsel the patient. The patient will need a pan-retinal photocoagulation as soon as the view is good after the cataract surgery. Scenario 6 is a cataract surgery with a clinical picture like this, where there is an ischemic maculopathy. Some 5-6 years back, there was a lot of doubt whether in situations like this, whether we could give anti-VEGF agents, but large-scale studies and various meta-analysis have now proved that anti-VEGF is not really a contraindication in treating patients with ischemic maculopathy. Scenario 7 is a patient with cataract with vitromacular traction. We should definitely refer these patients for cataract surgery along with vitrectomy. These patients are really not going to do well with cataract surgery alone. So is there any role of laser in this era of intravitreal pharmacotherapy? Yes, there is definitely a role of laser. If you see a patient with a clear-cut circinate retinopathy like this, obviously you would like to do a focal laser to the center of this circinate before you do your cataract surgery. And coming to my last scenario, this is not a very uncommon scenario where you operate on a patient with a patient with a diabetic retinopathy, and the patient develops macular edema post cataract surgery, and you are really worried whether this patient edema is a pseudophakic macular edema or it's a diabetic macular edema. This is a common clinical conundrum. In this situation, what we tend to do is you can do an angiography. And the good way to differentiate between a diabetic macular edema and a pseudophakic macular edema would be to look at the disc. The pseudophakic macular edema, you will get a hot disc, whether in the diabetic macular edema, the disc would be silent. Here, this is a leaking NVD. Because the treatment is diametrically different. In diabetic macular edema, you would like to treat the patient with anti-VEGF, whether pseudophakic macular edema will respond well to NSAIDs. If not responding, you would like to treat them with a simple steroids. Here, it's a pseudophakic macular edema. The disc is hot. It's a diabetic macular edema where the disc is cold. Disc staining is seen in inflammatory CME or pseudophakic macular edema. So this is how we should differentiate between a pseudophakic CME and a diabetic or a diabetic macular edema post cataract surgery. So these are the basic situations which the common situations that the cataract surgeons can face in their day-to-day practice when treating a patient with diabetic macular edema. Thank you very much for your kind attention.
Thank you, Rupak, for taking us through the management of a situation where you need combined treatment. Any comments from Mohan Rajan, sir?
I think it's a beautiful talk by Rupak because we see this scenario almost every day, and we operate almost every day with patients with diabetic retinopathy, cataract. The thing is, the certain protocols to be followed, of course, pre-operative, intraoperative, post-operative, you have mentioned beautifully, starting them on pre-operative NSAIDs and continuing them for about 2 months post-operatively. Even for the steroids, topical steroids also, I'll push them for a longer time as well. Because the reason why, because post-operative inflammation is more common in diabetics. And always use a hydrophobic lens and prefer to put the lens in the bag. And because many of them have small pupils as well, you need to make sure that you dilate the pupils very well intraoperatively. Inflammation is little more. And the prostaglandin release is more, inflammatory cytokines is a little more. And that I can add on to the aggravate the diabetic macular edema, the diabetic retinopathy as well, and add on to the pseudophakic macular edema component as well. So what I do normally is all these patients, whether they are having diabetic retinopathy or not having diabetic retinopathy, I treat them very aggressively. Some of the patients, I start them even preoperatively on nepafenac and continue that post-operatively for about 2 months. And phacoemulsification is very, very important, making sure, even because many of them have hard cataracts as well, and little older patients, and make sure that you use the cold phaco technology, good viscoelastics, OVDs, and making sure that you are having absolutely a posterior plane phacoemulsification, because corneal edema is something which is very, very common in diabetics, and this endothelium is also not very good when compared to the normal population. So corneal edemas, it take a longer time for the cornea to clear up. The corneal edema doesn't stop with the corneal edema. Sometimes, many times, not sometimes, many times, lot of inflammation occurs with corneal edema, and that can account for something like a fibrin reaction on the surface of the lens, or even contribute to the intraocular inflammation, and even contribute to the cystoid macular edema as well. So all these, I think it's everything we need to take care of in cataract surgery in diabetic patients. And of course, systemic control is very, very important. So just last week, I had a patient had a mature cataract in one eye, and the other eye had a pseudophakia, and the other eye had pseudophakic, macular edema, clinically significant diabetic macular edema. So what I suggested was, for the other eye, I did intravitreal Osidex. This eye, I told the patient that I will remove the cataract, put a lens, and have a look intraoperatively, because most likely this patient will have a macular edema in this case also, because it's more or less symmetrical. So in this patient also, I had a look intraoperatively and gave an Osidex for this patient also on the table. So like this, you decide on the table sometimes when the patient has got a very mature cataract. Many of them come with very dense cataracts. You're not able to assess the posterior segment properly. Intraoperatively, you can assess that and change your game plan and your plan accordingly. These are my 2 cents as far as the cataract surgery in diabetic retinopathy is concerned. And of course, yes. Anything you want to add, Rupak?
No, absolutely agree with you, sir. Perfectly, sir.
So I think great talk, Rupak. One point is about pseudophakic cystoid macular edema. I think the OCT itself, that high characteristic, high volume to CRT ratio, will actually clinch that probably we are dealing with pseudophakic CME compared to a diffuse diabetic macular edema that we see. So that high volume to central ratio in the central part. In fact, there are even AI models have come into the algorithms that these are the pseudophakic CMEs and these are the regular DME.
So I just can I make a point?
Yeah.
In cataract surgery, these patients tend to have very dense corticocapsular adhesions, diabetics. So while doing cortical cleanup, sometimes if you pull very aggressively, the cortex is very densely adherent to capsule. You can have zonular dialysis or even the posterior capsular tear. So you have to be careful about it. Secondly, when it comes to doing laser for diabetic macular edema, I think we see patients who are not responding. Sometimes they have very large dilated vessels, PVAC kind of lesions, and you do targeted laser to this, the macular edema kind of vanishes quite dramatically. So if you are sure there is no traction, vitreous traction in the macular area, and you see these very significantly dilated, uh, dilated, my, you know, microaneurysms or aneurysms, you can be very sure laser is going to work. So, couple of observations.
Another important thing is, I think, as I told, in the bag implantation is very important. Make sure that you're not ending up in some complications like posterior capsule rupture. And in the posterior capsule rupture, in a normal patient itself is quite bad, but in a diabetic, it makes the life little more. It's adding fuel to the flame because all the complications can occur. Whatever diabetic retinopathy can occur. I have a patient after a PCR and sulcus implantation. Within no time, within 2 to 3 months, he went from mild NPDR to severe PDR. So something which is, you cannot even say, in the pseudophakic macular edema is quite common PCR as well. So you need to make sure that you take all the precautions. And corticocapsular adhesions, you have to be very careful, especially when you're doing the hydrodissection, because there are very little, there is a lot of capsule and the capsule and the cortex is so badly adherent. Sometimes it's very difficult to. There are a lot of fibrotic areas in you can see that in diabetic cataracts as well. So I think all these are very important. In fact, tomorrow I'm giving a talk on cataract resection diabetic retinopathy in the Kerala State Ophthalmic Society webinar tomorrow, same for the World Diabetic Day. So
great. So, Rupa, great talk and really enjoyed all the scenarios. As Manish was telling, these macroaneurysm type of microaneurysms actually, somehow they can also be picked up on ICG. So there have been group who have been doing ICG to pick up those, and even I have done on a couple of them. Some of them, because of massive exudation, you may not see those larger aneurysms. OCT is again good, and OCT you can actually see a closure. The moment you do a laser and again repeat the OCT, you can see those becoming black. So that's something you can treat. And I think what Dr. Mohan Rajan said is very important, that progression of retinopathy is seen. The good thing about progression is that PDR progression happens late. So early progression, very rarely you get. It's late means I'm talking about 6 months. Immediate progression is about 5 to 6%. Late is about 20%, and that is actually PDR. So that's something after cataract surgery you must realize. And definitely in about 20-25% cases, you'll have worsening of DME. I think that is something, again, you need to keep in mind. If preoperatively there is very less edema or maybe non-center involving, it can become center involving after that. So that 20% of them, and that develop within 3 months. So if first 3 months that worse, so you have pseudophakic and worsening of DME both. Pseudophakic macular edema can be there, and many times you have mixed varieties. You can have both the components present. So simple trick is look into lesions of retinopathy. So many times, like what you look for is the disc leak is good, but look if there are leaking microaneurysms there, other lesions of retinopathy, you consider it as mixed and treat both. If you want to give them your steroidal and non-steroidal, but also want to take care of the diabetic macular edema.
Yeah, excellent. So actually, the purpose of my presentation basically was to dwell on the broad guidelines.
No,
so,
it was fine. Very good.
Yeah,
You
and
covered
more so on the as Mohan Rajan was concentrating more. Dr. Mohan Rajan was concentrating more on the cataract part. Mine was more on the basic guidelines on the retinal part, as you correctly said. These are core retinal issues. I just focus on the core principles, which probably a general ophthalmologist or a cataract surgeon can manage on his part, can think of in his clinic while treating a patient with a cataract with a diabetes.
Absolutely true.
Yes, Swapnesh.
Yeah. So I have a question for all the seniors who are doing cataract surgeries, being retina surgeons. If a scenario is like this, that the patient has a mild NPDR with no DME and HbA1c level is well controlled and no other comorbidities or maybe just hypertension is there, and patient wants to get rid of near glasses. So what would be the choice of IOL? Ring-based, trifocal, or a extended depth of focus, or we stick to monofocal? Age group is say 60, 62.
Now we can go for enhanced monofocal lenses, or we can use, I use even EDOF lenses for these patients, and they do pretty well. If they don't have any diabetic macular edema, they do pretty well as well. No problem. As long as you explain to the patient that there's a possibility of future progression of the and developing macular edema in the future. So, but they do pretty well. So that my general choice for me would be, I would not use a trifocal lens, because the trifocal reduces the contrast sensitivity, and diabetics already they have a reduced contrast sensitivity. So trifocal splits the light, whereas EDOF lenses don't split the light; they stretch and shift. So that's the advantage. The contrast is very not lost much. So that's the advantage. Or enhanced monofocal like a High-Ans or the Impress lens will be very good for them. Make them monovision. For example, one eye you correct for hemetropia, the other eye you correct about 0.5, 0.75. And there's an inherent quality of these lenses which will make them give fairly good, what you call, realistic near vision. Yeah.
I think just adding one point which we recently published was the IUL Master has got a swept source OCT. So you can use that swept source OCT to determine whether it is a center involving DME or not. Because many times anterior segment people who don't get a OCT done and they have a IUL Master, you get the center 1 millimeter.
Correct.
So don't see the dip. That means definitely there is CIDMA and you need to tackle along with your cataract surgery.
But sometimes very mature, hyper mature cataracts, even the IOL Master does not.
There it becomes a problem. Yeah, where
Almost near total it goes. IOL
Yes.
Master picks up that. But
Correct.
I was talking about this thing, is the total cataract, absolutely no view, and IOL Master also didn't. I had to do an immersion A scan for this patient to get the biometry
Most
value.
cases you cannot, but if there
Intraoperatively
is reasonable view and you are using, you can use your IOL Master. You can still get to know whether there is center involved.
Yes. IOL Master.
Without OCT.
Very good.
Points well taken from everyone, and as the scenario is of enhanced depth focus lenses, my plea to all of you once again is, let's get our focus for the AIS elections votings as well, and try to generate as many votes as possible for none other than Dr. Mohan Rajan sir. And we need to make sure that he wins hands down with a very effective margin. It will be not good for the society, but it will be good for our alumni association as well, as we can progress together for the betterment of ophthalmology in our country and overseas as well. So with this last few words, if we don't have any other comments from any of the panelists, we can close down this session.
Yeah, 1 minute, Manoj. And now I would like to thank all the chairpersons, the panelists, the speakers, and of course, moderator, Dr. Manoj, for the wonderful webinar. This webinar, we are having it on every second and fourth Wednesday between 8 and 9:30 p.m. And next webinar will be on 27th November on uveitis. So I'm requesting JB and Partha Pritham to formulate the program for this. I don't want you to use this as my election this thing, but I'm just telling you. But that our SN alumni, as I told you, is the strongest. But I think we should show the solidarity this time. And people like Rajiv Raman and Dr. Natarajan and all other people who are here are all big people, and I'm sure they will be able to give us a proper this thing, and so that we can go forward and make sure that.
I agree with you, sir. And I think this platform, we should use this opportunity to tell our alumni And I think we have been always not, no, that strength of alumni is not seen. Hardly few people come forward to take the responsibility in AIOS, and those who are coming, if we don't support, who will support? I think that's something as a family we need to.
Very good message. And
That's what I'm saying. If all of us come together, we can show our solidarity and majority, and also work for the betterment of society as well. It's not that the election is the only motive. Yes, sir.
thanks, sir.
So-
Thanks a lot. Thanks a lot.
Thank
Looking
you.
forward.
We'd like to also thank his INS Pharma for their
Yes, I want to forget. Yeah.
continuous support, and also Sai Numerotech for their constant support as always. And once again, thanks all the panelists, speakers, and the audience who have joined us from across the globe. I think today we had a very good response as per the Sai's report, and we will be keep doing it this every second week, and we look forward for participation for most of the faculty, most of the SN alumni as faculty in the webinars. Thank you so very much once again.
And also, Manoj, please, Sai, if Sai is on the line,
Yes,
Yes,
Doctor.
the recorded program on the YouTube, can you send it across so that I can give it to everybody and put it across to all the
I'll send you the link, Doctor.
SN group,
I'll send you the link, Doctor.
YouTube recordings, okay?
Sure,
For
sure.
the last webinar also and this webinar also.
Sure.